we have Dr. Akshay Nair today, who will take us through the evidence part of it. Akshay Nair is involved in simulation-based training, publications. Let's hand it over to Akshay, the expert on publications. Akshay, over to you.
Thank you. I think we've heard enough of how simulation can help train people, but I think the proof of the pudding is in the eating. So we've trained people in simulation, they've operated, but has it really helped in improving outcomes, in improving patient safety? And that is what we'll be looking at. These are my financial disclosures. So before I jump into the evidence, I just want to give an overview that while we've been focusing on virtual reality-based simulation training and especially the Help Me See Eye Surgery simulator, simulation is not just limited only to virtual reality-based simulator. There are a lot of different types of simulators, like clinical skill simulators that can help you train in direct ophthalmoscopy, indirect ophthalmoscopy, laser procedures, like the Reti-Eye or the Simuli, where you have small little fundi that are 3D printed and enclosed in an eyeball on which you can practice how to focus and take laser beams. Similarly, you've got animal models, human cadaver models, you've got virtual reality based models, inanimate object. So we largely hear about wet lab, dry lab, and the concept of how these two are distinguished. So we call them wet labs because they're basically using chemicals and tissues that can be wet hazards. Like in this photo, you see a goat's eye that has been, in which the nucleus has been removed and a delivered nucleus from a human eye is then put in, and then phacoemulsification is being done in it. So this is where biological tissues like human eyes, animal eyes, especially rabbit, pig and goat's eyes are used, or we can even use vegetables, fruits, or a combination of all of these. You also have wet lab training where inanimate or artificial eyes are being used, like this kit or the Kitaro eye kit, where you've made a paracentesis, created an anterior chamber, filled it with viscoelastic, and on a cellophane tape you're doing a capsular access on there, so you can learn how to do the task and the hand movements required in capsular access. But as you can imagine, each attempt that is done utilizes one eyeball, and therefore the kind of expense that goes up with these kind of training devices is quite high. As is with this, the Vetret Philip eye used for vitrectomy, or a stretched out taut aluminium foil used for capsular access. So how do we know it works? Dr. Kimya Chavan briefly described about how surgery is, how training is performance on the simulator is assessed. There can either be a cognitive skill assessment or a technical skill assessment. And we spoke about the IC133. Now, IC133 is basically, OSCAR stands for Ophthalmology Surgical Competency Assessment Rubric. This is there for phaco and SICS. Now, similarly, there is also a SIM-OSCAR, where you are able to assess the performance on a simulator. And this has also been validated by Wildean's group, where they trained trainees in Africa on a simulator and compared their performance on the simulator and try to correlate it with real life surgical performance. There are different other virtual reality based simulators that have inbuilt scoring system and assessment, and we saw a bit of this. Now I'm going back to the Help Me See Eye Surgery simulator, where you can see that here the trainee is trying to deliver a nucleus, and while delivering the nucleus a complication is happening. So it gives you the alerts that there is zonular damage. And while it gives you the alert that that is happening, the trainee knows, the instructor knows, and of course, as was mentioned in the previous talk by Dr. Kimya, how the simulation-based learning system captures all this information and gives you a scoring and tells you whether your attempt was a satisfactory one or not. So the advantage of virtual reality-based simulators, as we've been harping on and repeating ourselves, is there's no worry of collateral damage. There is no worry that if I have a run out, if I have a posterior capsular rupture, what will happen to my patient? Because here the advantage of being able to learn, relearn, unlearn, and do multiple attempts without stress or fear remains there. Additionally, the visuals, the graphic, the depth, and the haptic feedback add to the realistic learning value. Now we've figured out how simulators assess things, how performance is graded on the simulator. But does that mean anything? Well, we go back 10 years ago in 2013, this was the first paper that actually published how simulation based practice improves performance of capsular access by trainees in an operating room. It improves intraoperative cataract complication rate, and therefore based on papers like this in the UK, now there is a mandatory 60-hour requirement of all ophthalmic trainees to undergo simulation based training before graduating into live surgery. Similarly, papers from Scandinavia have also been published, and we've also presented our construct validity study recently at ARVO. Again, capsular tension ring also has been studied, and this was our crown jewel, the publication that we had a couple of years ago, a randomized control trial where we had trainees who came in from 3 institutes, partner institutes, who came into Mumbai, learned on the simulator, went back to the parent institute, and their first 20 surgeries were recorded. Similarly, the control group who learned surgeries at their own parent institute and then started doing live surgery, again, their first 20 surgeries were also recorded, and the first 20 cases of each of the 2 groups of trainees was masked and reviewed by blinded observers, and then they graded these surgeries based on technique, outcome, and errors. And the analysis showed that the number of errors by the control group, or the group that did not learn on simulation, as you can see in the orange colored bars, were significantly high. It was high for all errors, significantly high for major errors, and for minor errors. So if at the end of the day you're able to reduce errors and complication by a trainee simply by putting him on a simulator rather than making him operate on a real eye, imagine the amount of benefit that patients can perceive from this. So simulators allow you to have different assessment tools in a stress-free environment with minimal collateral damage. Even though it may have some amount of expense associated with it, there are long-term benefits because it allows you to have customizable scenarios, and it has changed the landscape of training. And at the end of the day, while we are improving technique, we are improving skills and confidence, the most important thing that we are improving with simulation-based training here, along with the Help Me See Eye Surgery Simulator, is patient outcomes, because that's the only thing that matters in the end. Thank you so much.
Thank you, Akshay, for getting us through the evidence, and I'm sure we are all excited to also have a similar study done for phacoemulsification. So let's build up on that when we get back. But thank you for the wonderful talk, all the speakers. It was great. I invite sir to have questions. You're the only interactive audience we have. So do you have any more questions, comments? Please use the mic. Feel free to use the mic.
No, I think it's difficult to say that it's the end, but yeah, no, I think it's not always, in places like India and Africa, it's not always easy to dismiss non-simulated, traditional training because of resources that are limitedly available. So I don't think it's the end, but there's a clear advantage in simulation. That's all I can say.
So at the moment, sir, there is a role for everything. It's where you place it in surgical training right now. Once we go through that path, and we know that this definitely is going to be the future, we'll gather more evidence. There will be more partners like Arvind, and probably then you can say that it is now coming to an end. But right now, the way it is placed, I think it only adds to what you already have. It only adds to the current surgical training in reducing complications, as Akshay said, in improving patient outcomes. That's what everybody wants, right? So the entire effort that Help Me See's a virtual reality simulation based training platform puts is getting confident surgeons and reducing complications, thereby increasing patient outcomes. That will also come down. The more it's like the catch and mouse situation. The more people get involved, everything comes down. So yeah.
Sir, sorry to interrupt, sir, but sir, nowadays they're getting more stipend than what I'm getting, sir. So they can easily be, for their career, they can pay, sir. But having said that, sir, everything comes with a price because for you to tell you the real truth, till date, Help Me See is doing it for non-profit. They are not charging anything. We are charging it on our side to help them become little sustainable. So it's not like they're aiming for the money part, but only when you pay something and come inside, you will learn it seriously, sir. Because if you take an institution, if you sponsor it, you're eventually going to ask that surgeon to come back and show his performance. So if everything is going to be for free, there isn't going to be any seriousness in the time they spend with us. So
And sincerely, we are teaching them from 9 to 5, so that goes without saying, right?
Right. Any more questions? We are good. I think we are well within the time. Thank